Tēnā koutou katoa. Welcome to the inaugural International Learnings Webinar Series 2025, with the hope to bring insight and inspiration from leaders across the globe. So before we begin, I will open us up with a karakia or blessing in te reo Māori, and then introduce myself. All right. So first and foremost, me mahi tahi mātou, ka kōrero, ka whakarongo, kia atawhai, kia manaaki, mō ngā whānau mino hapori katoa. Kia rātou te tino rangatiratanga I o rātou hauora. Kia pai te taha tinana, te taha wairua, te taha whānau, me te taha hingangari hoki, haumi e hui e, tai ki e. So for those joining us outside of Aotearoa, that blessing was saying that we will work together and communicate with kindness and respect for the benefit of our community so that people will have self-determination or autonomy over their health and well-being for a well body, spiritual well-being, family well-being and mental well-being. And together we will do this strong. So tēnā koutou katoa, ko Coral Fitzgerald toko ingoa. So greetings, my name's Coral. I'm based in Aotearoa, Christchurch, here in the South Island of Aotearoa, New Zealand. I'm one of 4 passionate staff members who work for Collaborative Aotearoa, and I'm delighted to be facilitating the session today, which is noted as our inaugural International Webinar Series event for 2025. For those new to Collaborative Aotearoa, we have a pursuit of equitable health and wellbeing for whānau and communities across Aotearoa, and that's at the heart of everything that we do. So through collaboration with our amazing membership organisations across primary and community care, we are deeply committed to expanding our reach to ensure transformative change to the healthcare delivery across Aotearoa to better support our whānau or family across the country. So a few housekeeping notes before I introduce our speaker for today. You'll notice the session is being recorded and will be available on our website over the next 24 hours. You'll see that the chat function is turned off, but we do welcome and encourage you to post any Q&A into that function there. You can also interact using the React button. And just a note, I have my lovely colleague Nee in the background supporting us and who will monitor the questions and answer part. And we'll have some dedicated time at the end of this presentation to explore those as they come through. So it's now my pleasure to introduce Chris Reid. So originally from the UK, Dr. Chris Reid trained at University of Newcastle Medical School before spending 10 years in the Royal Marines. In 2004, Chris emigrated with his family to New Zealand and was a GP in Kerikeri up in Northland and an elected member of the Northland District Health Board, as was known back then. Now back in the UK, Chris has taken up the role of Chief Medical Officer for the NHS Cornwall and the Isle of Scilly, and his interests continue to be integrated health models and most recently the rollout of neighbourhood healthcare teams in Cornwall. Good evening, Chris, for you. Thank you for joining us. It's the late hours of Monday evening for you, and it's great to have you here as we launch the webinar series. And I think I'll speak on behalf of everyone here who's either seeing it live or watching the recording. We're so excited to be able to hear about your experiences both in Aotearoa and also in the UK, and particularly the leaning into the approaches to tackle a number of inequities, including increasing frailty, the deprivation factors and challenges of rural and remote rural areas. So look, I'll hand over to you to start your slides.
Thank you, Coral. Thank you for that lovely introduction. So kia ora, everybody. It kind of feels like I'm talking to my home crowd, I have to confess, and I recognise some names, so it's lovely to see some of you. But yes, I'm in Cornwall and the Isles of Scilly in the bottom corner of England. If you turn it 90 degrees clockwise, it kind of looks like Northland. That's what I feel if you look at the map, and it's actually quite similar. But I'm going to give a quick overview of, I'm just going to try and get my slides to move. So I could give you a really short version of my slides, which is if you can get your population to eat well, move, sleep well and socially interact, you've cracked healthcare. But I wish it was as easy as that. But I always remind myself of that when I'm a GP, that's probably the most important thing you can get your population to do. But I'll give a quick overview of what our current situation is in England. And I just want to say I'm speaking just as me. So even though some of the slides have got NHS logos, it's just my own personal opinions. I've brought some slides that we're using, but please, I'm happy to say, I just want to give my own opinions on this. So what I'm talking to you over the next 30, 40 minutes or so is just my own opinion. And I'm not speaking in any formal capacity. So I'll give you an overview of what the NHS is facing, and you'll probably see some very similar correlations to what's going on in New Zealand. A little bit about our structure and how it relates down in Cornwall. We'll talk about health inequities and the challenges there. Talk about what excites me is the beginning of the rollout of integrated neighbourhood teams. Again, you'll see some similarities with the neighbourhood healthcare home model in New Zealand. And we're just starting to see some quite effective use of AI and digital tools. So just to give put it into perspective, we've got an aging, frail population, and it's a big problem. And the location of that aging and frail location, if you look at the map, what we're predicting to be in 2043 is there's going to be a significantly increase in that cohort of patients, but they're going to be tending to live in the rural and coastal areas, which tends to be where your young workforce doesn't live. So workforce is a challenge, but also you've got increasing areas of deprivation and increasing areas in those rurality, increasing and an older age group. This is us in Cornwall, and again, I think you'll see similarities with parts of New Zealand. We've got a bit of a cost of living crisis. We've got a lot of mental health issues. 33% of our residents in Cornwall live more than 30 minutes away from any large centre of employment, so difficult transport issues. It always catches me out, 70% of households in Cornwall still don't actually have access to a car, and public transport could be a lot better. We've got 16% of our children living in poverty in Cornwall, which is a huge concern. So as I said, we're down in the bottom southwest, which is where I'm based. The NHS splits England into 42 integrated care systems or integrated care boards. So Cornwall and the Isles of Scilly, that are islands off to the southwest, are part of us, and about 550,000 people is the population. One major hospital, quite a few smaller hospitals, which are coming back into vogue. We used to call them cottage hospitals, but now we're redefining them as our community sort of frailty same-day emergency care facilities, and a splattering of GP practices. We spend about 1.4 billion on health. I think the last time I looked at I think that's about 3 billion of New Zealand dollars, and we're just shy of 200 billion as a total spend in England in terms of health systems. So we've got a 1.4 billion. Show you how busy we are, and I always like this because I'm biased, of course, because I'm a GP. So 4 million GP practice appointments last year, 800,000 hospital appointments. And that's pertinent when I come to some slides about showing you where the finance and the money is being sent over the last few years, which again shows us what our challenges are. I'm not going to go through those numbers, but again, we can come back to them if we want to. So just to put it into perspective, we've actually got 55 GP practices. We split it into primary care networks. We're going to network, in essence, we're renaming them integrated care teams, but there's going to be 16 of them just because we want it to be slightly more community orientated. And as I said, GPs are exceptionally busy, and yet they still manage to see an incredible amount of people on the same day, and still a lot of them face to face. So there's our spend, 1.4 billion, about 144 million on GP services, almost the same, 120 million on prescriptions and other services. So with the recent change of government in this country, Lord Darcy was appointed to give an independent investigation of the National Health Service. You can look at this online. It's a simple read. It's a really good diagnostic pointing out, but the two main themes are those with the greatest need have the poorest access to care, and the funding over the years has not gone to the right areas in our current health model. And if you're into reading documents, the other document I would read with this is Sir Chris Whitty, who's the Chief Medical Officer for England. He does an annual report, and he talks about the health and an aging system, which goes back to that first slide about how the population, the older population, tends to be in the more rural and deprived areas. Lord Darcy, just basically spelt it out. Over the last 15 years, our health system's deteriorated. We've got more people living with multiple long-term conditions. We're spending the money in the wrong place, too much in hospitals, not enough in the community. Our waiting times in ED have got worse, they've skyrocketed. And of course, that creates patient harm. We all know for so many patients who wait in an ED more than 12 hours, you start to see patient harm and increased mortality. Our cancer care and improvement in cancer care is really fairly static, and we're falling behind other countries. And an interesting thing about, he wanted to point out that redesigning the structure of your health system, which we did, actually created a lot of problems. So the solution is not necessarily to restructure and have a different management structure, because that took 10 years, as it said, to return to a sensible level of operating. And then, of course, we're all aware of COVID, and so we are, especially around our hospitals, we're not as productive as we are pre-COVID. We still haven't got back to that we're not as productive as we were, because we've had an increase in workforce, mainly in hospitals, and yet we're not seeing the increase in productivity. So again, I'm sure this is exactly the same as the population in New Zealand, which is because the population's getting older, they're not only getting older, they're getting more and more conditions that they're living with. So as you can see, 75% of those over 85 have more than one long-term condition. I think about 60% have more than two. So that adds to the complexity for the whole health system, in particular primary care. Just a few slides to emphasize what Lord Darcy picked up, that our waiting list times, that's the over 65s, but the graph looks almost identical for under 65s. So we're really struggling, and we're getting long waits in ED. And this is one of those graphs where I think it should make you feel really uncomfortable, and it upsets me, which is around, if you can see clearly, if this is the colours are divided by most deprived to least deprived areas of the country, and you're much more likely to be rapidly referred for suspected cancer if you live in a more affluent area. So in other words, you're going to access care in a timely and appropriate way, possibly need to be investigated and have your cancer diagnosed rapidly, compared to if you live in a more deprived part, you tend to present as an emergency, and often therefore too late, where it's spread. So that's just calling out the health inequity. Another really interesting, I think, thing is, although you can say we are living a little bit longer, so this is since 2008, we're living longer, but we're living also longer in poor health. So back in the 2000, this is for there was 10 years of in poor health, 67, what I would call with a good health span. And why this is relevant, because if you put this in relation to deprivation, and you can see that if you live in a least deprived area, you only have about 15 years in poorer health, even though you live longer, compared to the more deprived areas where you're going to live shorter but spend 26, almost 10 years longer. This is for women, and it's even worse for men. So you have a significantly longer part of your life in ill health. And I know Chris Whitty would say this is the part that, that's what we could go after, because there's no reason for that to happen. That's a fixable part. So if we can make people spend less of their life in poor health, that would have massive impact on the health system. And again, I'm a GP, so the purple, as you can see over the years, the purple area is being squeezed, so there's less money being spent in primary care and general practice, and the bottom sort of bluish colour, there's a slight growth, so more money is being spent on secondary care. And again, that then emphasizes the fact that GPs, our totality of GPs, is fairly static. If anything, it's dropped a little bit, and most significantly, it's dropped in GP partners. And I know that can often be a sort of emotive discussion around what's the business model of general practice, and that's maybe a conversation for another day. But you can see the reality is we've got less and less GP partners. We have got increasing salary GPs, but that's not compensating. But overall, we need more GPs, and we're not getting them. So Lord Darcy, which is formed the beginning of what's becoming the NHS 10-year plan. So there's a new 10-year plan, and right now we're in public consultation. But they've already said there's going to be 3 themes in the next 10-year plan. And the 3 themes, the 3 shifts or channel shifts or reforms is going to be from acute hospital to community-based provision, has to be a focus. From the treatment of sickness to prevention, and from analog to digital. And again, everyone will recognise that, but I think it's just nice to emphasise that. And so their expectation is on, as we roll out and commission new care, we should be making sure it addresses those 3 themes. This is a slide in relation to Cornwall. So is that we feel we're kind of going in that direction already, but actually it's still quite challenging. So we do need to simplify and innovate care delivery for that sort of neighbourhood type theme. We need to think more multidisciplinary, especially in primary care, mental health in the community. Really important, we need to re-engage our staff. I think staff have felt very burnt out and disengaged, so it's really important we re-engage staff and re-empower patients. And I'll show you, the evidence is if you have an engaged workforce and community, you have a much better quality of care. We need to tilt towards technology, and we'll talk about that later. And of course, if you get people back to work, it helps with your nation's prosperity because there's less people off on sick leave. Lord Darcy said we want to hardwire financial flows, and I think lots of us have talked about what does that mean, but it's about making sure the finance moves into the community, so you're providing that care and you're moving away from that hospital-centric type model. We need to drive the productivity still in hospitals. That's something, and then we need to reform. So we can't just carry on doing the same thing. I think we all accepted that. I just thought I'd just play. There's 2 slides that are around. The NHS has a program around specifically trying to deal with health inequalities. It's split into children and adults, and it's called Core 20+5. So it's the 20% of your population and the most living in the most have the high index of multiple deprivation, so poverty. The plus is you also pick some specific areas. So in Cornwall, we would pick fishermen who often have poorer health outcomes, and it's a fishing community. And we also have the travelling community as well. So we need to specifically target them because they have increased health inequality. And then the 5 is that the key themes we know for children, we need to focus on asthma, diabetes, epilepsy, oral health, and mental health. And then for adults, it's the same criteria, but the health, the clinical conditions on maternity, mental illness, chronic respiratory disease, early cancer diagnosis, and hypertension case finding, with a sort of an overview of trying to get everyone to stop smoking. So our system priorities that we've had for a while, this is in Cornwall, we've realised that if we can address frailty and really have a targeted approach to frailty, and that in essence, our approach is trying to identify them, have that personalised care approach, try and keep them out of hospital, have alternatives to ED in terms of a frailty crisis, but also try and get people out of hospital quickly so they haven't got a hospital-acquired functional decline, which is a really big problem. And we need to deal with those long-term conditions in keeping with that Core 20 programme. And we also realise that our end-of-life provision is not as good as it should be. This is in Cornwall. We've got about 77,000 bed days a year that we feel are taken up with people who are known to be end-of-life. Now, some of those bed days will be appropriate, but that's 2 wards worth fully staffed, just dealing with patients who are end of life who probably should be having that care and palliation and end of life care in their home, or certainly in where they would like to choose to spend that period of their life. We need to focus on mental health. It is a significant issue around access across all ages. And that 24/7 service is not just about ED, it's about the 24 services, in particular for frailty and end of life. So that there's alternatives that just what tends to happen at the weekend or out of hours, the only place to go is the ED department. I'm going to skip over these slides because they're a bit too wordy, but and I want to get into integrated neighbourhood teams. So this is a big core program now for what we're doing in Cornwall. Is integrated neighbourhood teams, which is really around basing the care around our communities. It's one of those phrases that all of a sudden has become the catchphrase that is there not only to solve the health system and its problem, but when you think it's there to solve world peace as well. So I'm a bit wary of it's being built up now to be the saviour of the health system. I think it's definitely got it's definitely the right direction to go in, but I'm sure it's not without its challenges. But again, just to go over what we've already said, we've got increasing demand, we've got workforce challenges, we've got access challenges, we've got those specific challenges around frailty, end of life, what we call discharge to assess, trying to get people out of hospital on a reablement pathway, especially when you're frail, so that you don't block the beds. Again, having that ability to have what we call reablement pathways to get people home quickly is an issue. And historically, it's recognised there's been insufficient investment in primary care, which just means we've got overstretched services. So I think you'll resonate with because a lot of this is common sense, but we're trying to bring everybody who cares for and supports a community. So it's not just the NHS staff, it's social care and the voluntary sector. The voluntary sector are playing an increasingly important role. And actually, we're really fortunate here. They're fantastic in Cornwall and they're really motivated. And the key thing is you're making that team collectively responsible for improving the health and well-being of their community. I think of this as a bubble. These little circles, I think it's about understanding your population and trying to keep the care inside that bubble. Instead of it spilling into secondary care. We know that about a third of admissions to specialty wards and who go through the emergency department didn't need to be admitted. So if you look at them, and when we've recently done this in the last few weeks in Cornwall again, and I'd say it's even higher. Actually, if there was an alternative to ED, they could have been managed in the community. And of course, if you can get more upstream, you can stop that issue in the first place. So the idea is integrated neighbourhood teams should reduce ED attendances. They should reduce the likelihood for an emergency call out. So it's 999 in this country, and the 111 is not for life or death, but 111 is for urgent calls. There's 2 numbers that you can call in England. And the other thing, we feel like the ambulance crews, if you've got good integrated neighbourhood teams, it means the ambulance crews are more likely to be able to talk to the community team and discuss an alternative to having to just take them to hospital. So if they can understand the local need, they can prevent ill health. I think importantly, they can remove barriers and the nonsense of red tape that we often find between primary care and secondary care. So therefore, you can improve coordination and the quality of care, and we can improve. Actually, the workforce generally feels a lot better again, and so they have more feeling of feeling empowered and a sense of purpose. So if you can get a confident, sort of empowered, autonomous workforce, guess what? They tend to enjoy going to work more, and if they do that, they tend to look after their patients better. So this summarises kind of the 3 themes. So our Wes Streeting, who's the current health secretary in this country, that sort of is saying the hospital to community, treatment to prevention, analog to digital. And of course, that's that links into the Darcy's report about re-engaging the staff, re-empowering patients, shifting that care closer to home, and pushing the word into neighbourhood teams, which is why, as I said, they're being built up to be a big part of the structure and the framework of the future of what we're doing here. But I think the key component is that you're taking much more of a population health approach, so you can start to see the importance of data and dashboards and a framework to understand your population. We have this phrase called modern general practice, which has been happening in this country, which is around, digital systems, appointment systems, how patients access. It's okay. I think it could be a lot better. I think still sometimes it gets used as a barrier to deal with workload as opposed to giving the patients better access. We're trying to standardize our community health service so it's not so confusing. The multidisciplinary teams, and that includes secondary care coming to work in the community. So that's going to be one of the big changes we need to see. And again, all of you know, certainly when I was in Kerry, we had cardiologists, we had orthopedics come to work, but you're really trying to formalize that and making sure they feel as responsible for the population as the primary care team. The circle's been our sort of clinical strategy for some time down in Cornwall, which is, I call it all the P's, prevention, personalized, place-based, integrated, really focusing on reducing inequalities. And we know that the integrated neighborhood teams, especially when they're dealing with frailty, end of life, and that discharge to assess. So this is where we feel we're going to have our most, you could say, our biggest bang for buck. As I said, it's not new. And it's really interesting when you talk about getting a cardiologist to come and work in the community. Often the GP say, well, we used to have that. We used to have, we used to know that particular cardiologist we could phone. So sometimes this is just formalizing what was actually really good old-fashioned working relationships. Because I feel sometimes referrals now have become quite sterilized. It's very easy just to flick a referral. You don't know who you're referring to. So actually what we're trying to do is make the specialists be aligned to the neighborhood healthcare team, so they develop that collegiality and that relationships, and they get the buy-in. And we've had some small but amazing, already quick, signs of how impactful that can be. A pediatrician who goes to an area for what would have normally have taken him, I think, 9 PA sessions. So that's units of their time. He's doing it in 6. So he's about 30% more efficient because he's seeing the patients with the GP team and making recommendations. And for those few patients who then do still need to go to the hospital, they're much more worked up. And again, it creates a lot of efficiency. But the bottom line is people really enjoy it. They enjoy working as a team.
I love that, Chris. I've just got a query here, which links a little bit into your discussion a little bit earlier on, but the question came through from Natalie to say, do you see an increase in demand for services around seasonal changes, and how does that impact services? And if so, what innovations or models have you adopted to cope with the increased demand?
So we used to call it, we needed a winter plan here in Cornwall. Now we call it a seasonal plan. So Cornwall sees an influx of tourism in the summer, so that creates unique. But we also see the winter colds and uplift. So what we have done is, so we fund primary care hubs. So we fund additional GP appointments in the winter to deal with it. And what we can. Our GPs have been amazing. So when we had a recent critical incident when the hospital was full, because that structure was in place, we were able to suddenly provide another 5,000 appointments because the GPs were able to use that route, be funded for it, but they stepped up because the whole system was in a critical incident. So what we historically used just for winter, interesting, we're now starting to use it more of as seasonal, and so that we can actually be able to step up and step down a bit more flexibly.
Awesome.
So happy to come back to that. Yeah.
Thanks, Chris.
So what we've done is, as I said, we've actually got 16 integrated neighbourhood teams, And they've already really started to work and build up their multidisciplinary teams, how they're working with their community, how they're working with the voluntary sector. And what we're now doing, this wave one, is where we're getting them to face more into that secondary care space and say, right, how do we load bear the responsibility so that we take responsibility for the patients? And this is where the data becomes really important, because we want to see that that population reduces, there's less activity leaving and being sent to the hospital, be it outpatient referrals, unplanned admissions, out of weekend calls, and they're going to be monitored and asked to improve those high level metrics. Now, there's lots of things that they need to do underneath that, but that's the bit that gives the buy-in, as it were, from our secondary care colleagues, because they can actually see that the activity will reduce. But they need to be part of the solution as well. So our wave one, which we've started, is 4 integrated neighbourhood teams, where we're giving significant investment. We are giving the plan up to £6 million, so it's not an insignificant amount of investment. But as I said, it comes with a caveat that they need to show that they're decreasing activity that's going currently into secondary care, because that's the part that we can't, that's the channel shift that we have to actually deliver. What we're also doing, so we're saying, right, if you're going to become an accredited neighbourhood healthcare team, we want you to make sure you've got an active, proactive frailty care model, linking to what we've said around, because we know frailty is an issue. We want to make sure you've got a proactive end-of-life care model. We want to make sure you are cognizant and understand that what you need to do is reduce length of stay of your patient. So they need to be aware of their patients who do go into hospital and make sure they're trying to pull them out of hospital, because they know we can get Bob, Mary out of hospital because we've got the voluntary sector support. We can get them home. We need to get our specialist staff to come work in the neighbourhood health neighbourhood teams, and that's easier in some areas than others, because some are really keen and itching to do that. Some will say it's great, but who's going to do all the work I've still got to do in the hospital? So that has to be carefully managed. We want them to be have a specific improvement in NMSK pathway, plus at least 2 other outpatient specialities, say pediatrics or cardiology, and they have to take part in the data and the formal evaluation, because it's iterative and there's going to be a wave. I'm sure it will evolve and we'll fine tune it as we go. And I think we're aware that we know this from other systems where, and again, this will resonate with some of the models that have happened in New Zealand. You need to be brave. You need active champions. You've got to give people the time, afford the time, resource the time, as well as the commitment. Get that feeling of bottom up. So even though we're providing a framework, how they do it is up to the neighbourhood health integrated neighbourhood teams. But the framework that we're measuring them on is the same. So they all know what the exam question is, but how they do it is in essence up to them. So there's not one size fits all. And I think the biggest thing I always say to everybody is your working day has to change. So if you think you can do this by just having some name change, or the respiratory physician comes and does a clinic once a week, isn't that lovely? That won't work. You have to change. You have to change your traditional working week quite differently, and you have to get away from being reactive. You have to be much more proactive. This is what I get asked a lot in my new role as a CMO. Yeah, but where's the evidence, Chris? Where's the evidence to say that this is going to work? So we're working with a strategic partner called the National Association of Primary Care. They've done the meta-analysis. Yes, you can find research to say that this sort of community integrated approach is cost effective, it saves money, improves quality. But what's interesting is no one, and this is an honest, no one's ever pulled money out of an acute trust because of an integrated neighbourhood team. They've made theoretical savings, but this is where you need to be brave, because we're in this where we're going to have to move that resource. So I think there's a certain amount of a brave step, but we have to believe that we can do this. And the evidence suggests that if, again, and I think I referenced this earlier, if you have motivated, activated staff, that's really important. These are the four sort of foundation stones that you need. You need to have the integrated care, again, removing all that unnecessary red tape, bureaucracy, silly referral forms, etc. Different digital systems not talking to each other. But you have to have activated citizens. I call that health literacy. I've always called that health literacy when I was in New Zealand. If your patients know how to look after themselves, eat well, sleep well, move well, interact, but also know how to access health in a timely and appropriate way, that's how you can help make a big difference to timely access. And then you have to have those integrated teams. So our modelling, this is based on 800,000, not 500,000, is quite outstanding, the alleged savings we are potentially going to make by doing this. Of course, this always excites the chief financial officer. This is what when we're doing our business case. I think, because we do need to show that there's a return on investment. So the evidence is suggesting that this sort of number can be saved by applying this approach. So what does that mean? And we think that means 7% reduction, for example, in the cost of high care intensity patients, reduction in GP demand, quite importantly, that's really important. That gives back a bit of capacity. Certainly a reduction in outpatients and ED attendances, and most significantly, a reduction in bed days. So this is probably the most important slide because it's right what we're working on right now. So for this to work, we feel we need sort of 3 levels of data. We need that tier 1, that system level benefits. Is the integrated neighborhood team serving that population, making there's less ED referrals, reduced length of stay? And being able to look at that and monitor that is the most important. That's the high level tier 1. The tier 2 is there's a similarity to neighborhood health care home. What's the metrics that you're using within your integrated neighborhood team to drive that quality? What's your quality improvement process? And then there's that ability for them to buy in and understand it. So it's not just something the integrated care board's looking at. More importantly, the workforce at the coalface are driving this. I'm talking too much. This is our frailty model, I think, just to emphasize the bubble. So ideally, everything sits within the green. You've got your integrated neighborhood team. You've got continuity of care. That's something that's really important and need to be valued. But you have things like our community gateway hub is the voluntary sector. You have access to all of the voluntary service, that personalized approach. That's not just what's called a treatment escalation plan. Do you want to be resuscitated or not? It's much more involved about how do you want your personalized care? Where do you want it? How do you want it? What's important to you? And Brave Eye, which I'll just spend a few minutes on at the end, is an AI tool that we're using to risk stratify our population. Now, it's never going to be perfect, but if you get all of that right, then the care stays within that inner circle. But then there'll always be times when it doesn't. And then in our community, we've got our virtual wards. We've got what's called community diagnostic centres. You don't have to go to the hospital to get some diagnostics. We have 3 in Cornwall community called CATUs, community assessment treatment units. So your GP or the ambulance can send patients there. They can have CTs, bloods, scans. They can stay there for maybe 24, 42, 72 hours, go back to a virtual ward. And the most important thing is they go nowhere near an acute hospital bed, so they don't have that hospital-acquired functional decline. And we've even got now things like a mobile X-ray card. Again, so people in nursing homes who might fall, you think they've broken the hip, we send the X-ray card to them. And already that's shown to reduce significantly the amount of hospital bed days because you rule out the fracture. And so then they can be treated at home. But even if we've had a fractured knee, for example, it meant that they stayed there and then they almost went straight to theatre. So they missed out all of that, sitting in an ambulance for 12 hours, sitting in an ED for 24 hours. So that's been a great success. And then finally, there's that, there's the hospital, because you might occasionally need that hospital. But the key thing is our specialists are coming to work within that in a bubble. So last but not least, I thought I'll just give you what we're doing around Brave AI. Brave AI is just a brand of a digital tool. There'll be plenty of digital tools. But we are, so NHS England, we're what's called a vanguard. So we were really pushed to be part of the rollout of this tool. So the idea is if we support integrated neighbourhood teams to utilise state-of-the-art digital technology for proactive care, it will delay the onset of health deterioration, maintain independent living, avoid exacerbations of ill health, and reduce incidence of unscheduled health and care events. I clearly didn't write this slide for people who know me. This is not my sort of language, but it's a very digital type language. But the bottom line is, the idea is if you can use that tool to identify your population and do something about it, it works. And we've got some evidence to say it does. So yeah, but it has to, it's just one part of the tool. I'll just get to, so this is the side. So yes, if you're using the digital tool, nothing happens unless you do something with it and have that assessment, and then start thinking about the personalized care support and the interventions you might need, which are not always medical. What we're finding is when we identify people, a lot of things that are needed are social aspects to actually give them more support, not just about medication. So Brave AI scores people, your population, out of 100. So if the higher the score, the more likely you are to be going into hospital. It is uncannily accurate. So if you had a Brave AI score of 100, you would be going into hospital in the next few days, few weeks. So what you can do is you can analyze your population. You can do it weekly or monthly, and you can take your population and say, right, who's got the highest Brave AI score, and use your multidisciplinary team to say, right, let's take the top 20 and make sure we've got everything we can to wrap around care, make sure they've got a personalized care plan. So you realize you're in a very frail or delicate situation, chances are you're going to end up in the hospital. How do we work around this? And as I said, it's not always medical. It's not all the interjections you make are not necessarily always medical. The next bucket is really most frequent interactions with general practice. And we did this a little bit when I was working with Green Cross. We could look at, the worried with well versus the unworried well. And you can use a Brave AI score to do that and try and target your population. You can, again, look at whose scores going up the most rapidly. So there's clearly something going on, because the score last week was 40 and 3 weeks later it's 80. There's something going on. And then you can target specific cohorts, which is a bit more interesting, such as polypharmacy or a particular type of population, and see what you might need to do differently to improve that cohort. So I think I've talked about, yeah, you use that because at the high score, you're gonna end up in hospital if you don't do something about it. So Arbonex Primary Care. So Arbonex are a little neighbourhood team, and they were one of the first to roll out. So if you use this is an average score that they started doing, and their interactions happened in October. So the data goes back, but even though it's a small, you can see in October the line starts to move down. So the average Brave AI score is coming down, and that was, they looked at about their highest 60 patients and did something about it. And I said most of the interventions they had to do were not medical. And I know, because I checked on it last week, of the 60 that were looking like they were going into hospital in October, guess how many have ended up in hospital? One. So without this intervention, they reckon 60 would have, and it's pretty accurate, I have to say. The one who ended up in hospital only ended up in hospital for a day, because they'd already got the plan to make sure that person could be pulled out of hospital quick. What's fascinating about this is the primary care team are so excited by this. They're not doing anything radically different to what all of your teams will be doing, but they're using the data to show the impact. And it's just a simple use of data, them doing something with it, that's got them so excited, which is fantastic. So the frequent interactions, again, You can see when they started looking at this in October, just by targeting those people they realized a lot of that time was they're not addressing what their real needs were. They're not answering their questions properly. So just taking a different approach has already started to reduce that score. And then the most rapidly increasing again, something was happening to this person in September, October, and then they did something in the intervention. You can see it came back down again. So it's very simple, but it really energizes and motivates the workforce to start looking at their data. The one where they were looking at polypharmacy, and they're still trying to learn out what to do with that. And again, it just shows you that sometimes data doesn't always give you the answer. So they're trying to see if they can understand patterns, etc., in relation to their workforce. And this is a particular case of an individual where they spotted a rapidly rising score, and what they realized was there was no personalized care plan. The family were disengaged. The family weren't quite sure what to do, and it was just putting a personalized care plan into place, making sure the family felt well supported and knew who to call. The score came rapidly down. So I've whizzed through. This is my summary. I would say case for change is compelling in terms of integrate neighborhood teams and the need to do something. We've got to do something, and I think it's a good framework to base ourselves. We need to think about investing in primary care. Not about new staff. We can't get any more staff. We can't afford staff. Workforce is an international issue. It's how you repurpose your workforce, how you use your voluntary sector. Yeah, and as I said, I think we're pushing ahead in Cornwall because we feel it's the right way to go. And we don't. It's a fundamental change. But you could always just ask your patients to eat well, move well, sleep well, and socially interact, because that would work far better than anything else. So I'll stop for questions.
Awesome. Thanks, Chris. Gosh, that's brilliant. We've had a question come through actually from one of our team to ask about the Brave AI tool. Is that integrated into the GP's patient management system, or yeah, because this is still a work in progress, I understand.
It's not. So in terms of, does it sit as a score within the PMS? No, it doesn't. It's a separate tool. I'm sure it could be in time, because there's a whole heap of other things we're trying to push with integration of digital tools. My biggest thing I'm trying to push is, and I've pushed this for more than 20 years, is you'd think that you'd have in this day and age a single medication screen, for example. So if a cardiologist added a new drug or changed the drug, it would change in the community pharmacy record, the patient record, and the GP record, as opposed to writing a letter. So there's lots of things we can do digitally. We're not there yet. It would be relatively easy to put, yes, I've asked for the Brave AI score to be sitting in the patient record, but they're not using it in that way. They're using it to have much more, they're using it around their multidisciplinary teams at this point in time, but I'm sure it will come.
Awesome. That's brilliant. And I was just going to swing back, gives you an opportunity to have a wee sip of water if need be. You've done wonderfully. Lots of talking, lots of amazing gold nuggets. If I swing back to, you highlighted the need for motivated and activated staff. And certainly in Aotearoa, we're seeing evidence and hearing from across our system partners this is becoming an increasing issue for the workforce. So what I've heard is that in addition to these networks, which the data can help inform and motivate staff when they're seeing the wonderful change, especially that Brave AI tool, is there one or two other practical examples of how you can lift that energy for the workforce that you've seen?
So I think it is an issue. I think it's an issue not just in primary care but secondary care. I think a lot of the workforce are feeling very burnt out. I think we've normalised ambulance queues. We've normalised people waiting in corridors. I really feel for our emergency department colleagues. I think it's really tough, because we should not normalise that. So I tend to start with the question: if we were designing the health system today from scratch, would you want it to look like how it is? And I don't think no one has ever said yes. and therefore you say, so I think, so if we can just start to move in a different direction, I think it's about keeping it simple. So the nice thing about integrating neighborhood teams and that population approach, it's quite an easy concept to get your head around and say, so what would be what, we've used what's called the GP collaborative. We've set up a collaborative that where GPs come, and we've asked them, and of course they were screaming, saying it's frailty, it's long-term conditions that we are desperately needed help for, and so you say, well, what would you need? What would you need? So the integrated neighborhood teams is just the framework to allow them to start to put in the tools that they feel they can need. And I think you do have to talk about investment. But what we're saying is, you're not just going to get some cash and say, there you go, thanks for working so hard. The cash is with the caveat that you have to show that you're improving. So you're giving them appropriate resource, but you are making it really clear that you're empowering them to deliver a result that you said, but providing the data. So you and people like that. They say, right, that's my challenge. I can get that. That I know that if I can fix that, it's going to take the pressure off me. I'll have a sense of purpose. It's the right thing to do for our population.
And I think one of the words I highlighted as you presented is and I really admire the use of the characteristic bravery, because I think we can see in the evidence that where a person touches the system and has the greatest cost to them for their body, for their health, and also for the system, is more downstream in the secondary care arena. And bravery absolutely is needed, isn't it, to kind of flip the switch to say, actually, the investment to be in that preventative care and proactive care upstream. And that's huge. And in times of, we've got a lot of change happening across Aotearoa at the moment in health. And so I guess leaning into that, really keen to hear in terms of that mechanism for change, what are some of the other either characteristics or things that you've seen from any part of the system that demonstrates this lever of bravery to help shift that movement more upstream?
This is a little bit of a double-edged sword. Patient engagement, or engaging with the community and asking what they want. So if you engage with them without sort of giving them a framework or some data, the people will say, we need another hospital. We need, and because that's, but actually, if you say, well, actually, as a population, what you need is access to the right people and the right term. You can use digital way, what you need is that access at the right time. So I think bringing your population in and letting them be part of the co-design is really important. But you've got to do it. It's not just a case of having you have to think quite carefully how you do that, because you can go down rabbit holes if you're not careful. But so you have to do it, and you have to do it in a sort of guided way. I think the other element is, again, around letting people see population health data. So and embedding that into there. I think I said, how are you willing to change your working week? Because otherwise you're just on the hamster wheel, and you're so busy. But if you say, look, we need to move the dial on this piece of data, what would you need to do it? People have often got the answers, so giving them the time, and then getting rid of unnecessary meetings and being brave to say, okay, we'll allow you to say, so what do you want us to stop? And say, all right, fine, stop that.
Beautiful, love that. And just being very aware of the time, I've got time for one more question. I'll just, Vicky has popped one through for you, which is with the INT, who are the other partners? I imagine that the social and other needs of the patient cohorts that you'd need input or support and collaboration with including voluntary non-government organisations and other partners outside of health? And are they also supported to be part of the INT? And how?
So the short answer is yes, they are, and the voluntary sector has a coordination group, because we've got lots and lots of different voluntary organisations. So we've got the big ones like Age UK, Alzheimer's Association, but we've got lots of really localised voluntary sectors who are really fantastic. So we have what's called a gateway. There's a coordination of those, and on our ICB board, one of our board members is from the voluntary sector. So we are deliberately being very clear that there's targeted investment for the voluntary sector, and also we expect them to be part of the integrated neighbourhood team. The interesting thing is, by the way, they already are. So they'd already formed these community associations working together because they knew it was the right way to go. What we're doing is almost just turbocharging what's already in place, which is, I think, why we're very lucky that Cornwall's kind of already got a few rungs on the ladder, because we're seeing the importance. But using things like social navigators, where we funded, so people to help work in primary care to say, right, what you need is this, this, and this, and we can give you access. And so those people who've got sort of all of the connections is really important. We've invested in those.
That's awesome. I love the turbocharge approach, because you're right, there's so much great work happening already by those that see what needs to be done and want to be part of that movement forward. So that's amazing. Look, and we're at the time, and we're just about to head into the wrap-up side. It's been such a pleasure to have you present this and the amazing gold nuggets that we pulled out. I know for me, a couple of key things is particular. I want to head back in and have a look at that Lord Darcy report, and we'll share the link in the Q&A, because so much of that you can lift and shift and say this is happening in Aotearoa as well, and particularly the Brave AI tool. I think that's such a powerful way to positively look at population stratification and focus on those that have the highest need for care and proactively support those. So please do keep us updated on any further progress with data and insights. Awesome.
I think the Brave AI tool is just a tool, as it is what you do. And there'll be plenty of other providers of similar sort of risk stratification. It's
good point. Very good point. Yeah, I love that. Awesome. So before I close with karakia, just a reminder to everyone who wants to access the recording after the event. We'll have it on our website, which is www.colab.org.nz. So you jump onto the website and search for the webinar tab. And yeah, just want to take this opportunity to really thank you so much, Chris, for the session. It's been such a rich presentation of reflections and opportunities for us all to percolate on. And I think, and I would anticipate that all of us were able to sift and sort through a number of those topics and opportunities that you raised, to then take that into our forward approach for our journeys and all the various places we have in the health system. So yeah, huge thank you to you, and thank you for being part of the first event of this international webinar series. So we're really looking forward to continuing connecting with you down the line. All right, so I'll close now with karakia, and then we'll let you get on with your days. He karakia whakamutanga koutou. Kia wānanga mātou, kia whakairea te tapu, kia wātia ai te ara, kia tūriki whakataha ai, kia tūriki whakataha ai. Haumea huie, tai kie. Ka kite koutou.